slightly different. So what I'll do is, I'll redirect it in the laminar space. Okay. Could you appreciate, sir? Now could you appreciate the change in angle, sir?
Yeah.
Yeah.
We can.
So now we are in the space. So now we will take out the stillet. भूपेंद्र जी, मशीन को कुछ नहीं करना, सिर्फ ऊपर उठाइए. So you need to have that space to do the procedure. So now this is something which will be better appreciated in a live patient, because here the dural sac will not have a vacuum. That is one. And secondly, because of the toughness of the muscle, even movement and the classical LOR will be absent. But you need to go millimeter by millimeter, millimeter by millimeter. Confirming the position. So I am slightly cranial. I'll just try to get it into the I think I am hitting the bone. So what I need to do is, I just need to redirect it. Yeah. So what we will do is, we will just change it like this. Now can you see the tunnel view, sir?
Yeah.
Yeah. So now this is the, we don't need to change the direction. Once we go inside, we will be very sure that we are in the epidural space. We'll get the classical LO. Now here the classical LOR won't be there.
Yeah.
Okay, na? But this is, I think I should be in. So if you have to be like the, confirm the position. As I told you, one option is a lateral, other option is a contralateral oblique. आप 10 डिग्री इधर या उधर oblique कर दीजिए.
So I hope everybody knows what is LOR.
Oh, sorry, loss of resistance. I am so sorry. Loss of resistance. So basically,
used by the anesthesia people.
So the concept is that the dural space, the epidural space is a vacuum. So once you introduce, get the needle, and the needle punctures the needle punctures the dural space, so it will suck in air. So
epidural space.
Sorry, sir. Epidural space is like a vacuum. So once you pierce, once you pierce it, the air that you are trying to push, it will be sucked in. Right, sir? So you can appreciate that we are inside the space without. It can go slightly in as well.
Like the
Now this is. Now I am in the space. So if you want to get a better view, पूरा एक बार लेटल करके देखें. नहीं ऐसे ही करते थे.
Dr. Dhruv, we need to quickly move on to
Done.
So that
It's okay. Yes, sir. I'll have to find a supine wo, sir.
so we'll do it
in the demonstration, sir.
during the demonstration.
Done, sir. Thank you so much. Done, sir. एक बार लेट एक बार इमेज देख लीजिए बस.
Meanwhile, demonstrate
शोल्डर आएगा.
the stellate ganglion block. Dr. Surya,
हाँ बट ठीक.
please ensure that while the CM is being lifted, Dr. Moin session on ultrasound.
Thank you so much.
Thank you.
Thank you. थैंक यू भूपेंद्र जी, धन्यवाद, भूल चूक माफ, थैंक यू. माइक क्या करें?
Uh,
Can we talk? Hello? Me?
please put a mic on Dr. Mohini. Hello, hello. Yeah, Dr. Mohini, we are not able to hear you. Dr. Surya, you can explain at least.
Hello? Hello?
Yeah.
Can you hear me, sir? Hello?
Yes, Mohini.
Am I audible, sir?
Yes, please tell us. Please tell us.
Hello, sir. Hello, everybody. I'm Dr. Mohini. So, today we are learning about how to do an stellate ganglion block. We have learned about it in the morning class that it's made up of group of inferior cervical ganglions and the first thoracic ganglion. So, I'll show you how the anatomy looks like exactly. It's a bit different than in a normal patient. Like what we learned in the anatomy was there'll be a thyroid gland, esophagus, anteriorly and then posteriorly you can see a longus colli muscle. And the one, like, am I visible? Yeah. Okay. So right now what I'm pointing out is, so in this picture, in the ultrasound, you can see a rounded structure with an anechoic region in the middle, that is a carotid. And another elongated structure with an anechoic structure, that is the collapsed IJV. So what we can also see a very bright hyperechoic structure just below the carotid artery. That's where our sympathetic ganglion is. So, since it's a body, in a normal patient, the IJV is not this collapsed, so the margins will be a bit clearer, and also
You can also show the Cheshire tubercle so that rest of the things I think we
Okay.
can demonstrate them.
so my probe, I'm taking the pointer this side. So my probe, I'm keeping the probe pointer is medially, and I'm doing it with the level of C6. That is a Chassignes tubercle. So from medially to laterally, we can see the carotid.
Can you point it out?
Is my,
Yes, show us your finger.
yeah, okay. So this is the carotid. This is the nerve ganglion that we're targeting, and this is the internal jugular vein.
Yes.
In a normal patient, the jugular vein is not this collapse, it's the structure, the outline is better. So the needle will come, the,
No, but show us the tubercle also.
sure sir. 1 minute. थोड़ा bend करना पड़ेगा इसको, थोड़ा neck.
See, I think we can see the whole of the
Yeah.
transverse process.
Yes. Now we can see a structure here which has a posterior acoustic shadow.
Yes.
So this is the and very bright hyperechoic structure with the posterior acoustic shadow. This is the transverse process, and And we can also see a very bright structure here. In a normal patient, usually it's at the level of this, but since this is the body, we like cadaveric,
Understood.
so the anatomy will be a bit different than in a normal patient. So we can see here the ganglionic group of ganglion,
Okay.
and this is the carotid, and this is the IGV. So we keeping the structure in the middle is not possible at this point, because if I keep it in this middle, the whole of the needle tracking will be lost. So we have to insert our needle from this way, and going through the base of the IGV and also the carotid, we have to hit this point. This point.
Yeah, so
This is the line of the needle.
correct.
So I just tried to do it.
So we can demonstrate during the cadaver when they come down. I think placement of the needle, or you can do it. Okay. This black thing, which is a mountain, which is there, that is the Cheshire tubercle. It is not there in the other cervical vertebrates. Specific for C6. That's the reason you actually first trace it and then do that.
So
So you do it in plane, out of plane.
I'm doing right now in plane, sir.
So usually it is done in plane. So in plane, out of plane technique also they will show you in the.
So in plane, I'm doing an in plane approach. So you can see the needle here. It's a bit difficult because the neck is also not able to bend a bit. Can you see the needle up?
Yes, we can see.
Yeah, okay. So we'll go deeper. We'll go deeper. We'll go deeper. And we'll hit the nerve ganglion there. Maybe it's there. We just can you see it? The dissection?
Yes, we can
Can
see.
you see the dissection? Yeah, so that's the point. Thank you.
Thank you, Dr. Moini, for the excellent. Lights on.
Dr. Dhruv, for the trigeminal, you are ready? Hello? Hello? I think we can do it. So,
Because we got very late, I think the hands-on is the most made. So you have already have your stations. So we break immediately. Please, those who are assigned for the cadaveric, go down and
Sir, you want me to demonstrate or we do it in the workshop, sir?
you can do it in the workshop, sir.
Yeah, I think the CM will take time.
Okay. So we break up here. Please join your stations immediately. Your time starts now. So those who are here in the ultrasound station, please go, and lunch will be started at 1:30 onwards. So those who get free anytime in between can go and have lunch and do whatever you want and come back also. So lunch is like it's a running lunch, and those who are below also, after you finish your cadaveric, you can come and have lunch. स्टॉप कर दो, वो दो लिंक है या वही लिंक पे